Good morning, guys. So welcome to this core content lecture, and it's going to be about cervical spine fracture since this is ortho. And we'll specifically talk about unstable cervical spine fractures, okay? Oh, yeah.
Just click on the
So we'll start out with a case, then we'll talk about how to interpret this imaging. We'll talk about all the unstable cervical spine fractures. We'll talk about what criteria to use for imaging, evidence for spinal immobilization, rigid C-spine color, Skewara, spinal neurogenic shock, and the evidence used for steroids, okay? So we'll start with the case. We get, this is an actual case I had in CCT. We had a pre-notification for a gentleman that had positive head trauma with a GCS of 10. So we activated a level 1 trauma code prior to arrival. It was a 38-year-old male with no previous medical history that was brought in after a fall. The patient is confused and he thinks he fell approximately 12 steps, but he doesn't really know what happened. He denied any alcohol or any drugs, and he is not really adding much to the story. In terms of his physical exam, his vitals, he had a blood pressure that was kind of soft, normal heart rate, vitals were otherwise unremarkable. He had a small abrasion to the back of the head. He had point tenderness around C5 to C7, but no step-offs. He had a regular rate and rhythm, clear to auscultation bilaterally, soft belly. His neuro exam, he was only oriented to person and time. His GCS was 13, and we took on motor and on verbal, 1 and 1. He was only able to localize pain to the shoulders. His sensation was preserved to the neck. His upper extremities were flexed. He was only able to minimally move the shoulders, a deduction. He was insensate and immobile on the lower extremities, and he had an erection with poor rectum. In terms of the workup, he had repeat vitals, which were remarkable for hypotension, but no bradycardia, and patient was still maintaining as above. He had an EFAST, which was negative. He had a hemoglobin hematocrit that was adequate, and labs, which were grossly unremarkable. So in terms of what problems do we have for this patient right now? Head trauma. Sure. That is a problem.
hypotension.
Hypotension is a problem. Priapism. Okay. So in terms of the problem that I could gather, he was hypotensive with head trauma. He had a reflex tachycardia. He also had this paraplegia going on. Some sort of confusion versus intoxication, kind of unclear. So in terms of the differential diagnosis for this gentleman, what do you guys think is appropriate to think about?
Neurogenic shock.
Sure. What else? Hypotensive, we need to think about some sort of internal bleeding that we can't really see exactly with our EFAST. Okay, so we had either hemorrhagic shock, spinal shock, neurogenic shock, cervical spine fracture, anterior cord syndrome, since he's not able to move, we're blocking all the motor fibers, complete cord transection, and some sort of intracranial hemorrhage, and he's having some Cushing reaction with the confusion. So we got these images for him, and I'll play them for you, and I'm sorry, this is like ghetto video I took from my computer, because Epic doesn't let you screenshot anything.
Oh, you were looking at it.
That's not.
I didn't see it.
I didn't see it.
Of course. That's crazy. Play it again. Oh.
Where is it?
I don't see. Yeah, you do. I'll show you the other view.
Yeah. Right. I only did it because my patient on Facebook.
Oh.
Now I see.
Do you see it now?
I don't see it.
Yeah. That's in the wrong place.
I think that is overread.
COVID-9.
Correlate clinically. Right. What happened?
That's probably my dog or someone. So you want to see that one again?
Even the dogs.
You can see how they're all aligned there and you can't see anything below, and now the other ones are appearing. So just to tell you, it was read as a comminuted fracture involving spinocerosis of C6 vertebral body with grade 3 anthrolisthesis of C6 over C7, which is resulting in kinking of the cervical cord with cord compression. What else? He also has an epidural hematoma of approximately 1 centimeter. I can't see it honestly, but several spinal stenosis with cord compression and a fracture of C5 spinous process. That is the official read. They did not write correlate clinically. So trauma was at bedside when this happened. Trauma was like, well, I don't know what to do with this. Please consult neurosurgery. Neurosurgery said to get an MRI to continue an Aspen color with spine precautions and maintain a MAP over 90. Yeah, it was Brennan.
Oh.
Yeah, Brennan said to do dopamine drip or add on norepi if needed. And he got admitted to the surgical ICU for further care. So we're gonna. What's that? Okay. There's some beeping. So the relevance of why we should know about cervical spine fractures that are unstable is because cervical spine is the most prone to injury because it's the more exposed in the body, is the most mobile, and it's also the most flexible. And so the importance is that you have all the spine and the nerves going through there, and most importantly, your innervation of the diaphragm, which if you take out, then a person won't be able to breathe. So that's the most important thing. It's the most life-threatening because it decreases blood circulation to the brain. It can cause decapitation with full transection of the cord. And like I said before, you can have phrenic nerve injury and diaphragm function, which means that this person won't be able to oxygenate, ventilate on their own. The general indicators for instability is involvement of more than one vertebrae, increased or reduced intervertebral space, so in between the vertebra, if it's severely increased or severely reduced. If you have increased interspinous distance, if you have facet joint widening, and if you have vertebral compression of more than 25%. In terms of the imaging, you essentially want to make sure that all those lines, the arteriovertebral line, the posterior vertebral line, the laminar line, and the posterior spinous line are almost aligned. The spinous one will be the only that will be curved, but you can see they're all more or less in the same line. And that's when you take a look at these images, that's essentially what you want to make sure, that all the alignment is where it's supposed to be, and that there are no obvious fractures that can displace into the canal, chasm, some sort of spine injury. That's how it would look on a CT scan. And see how it should all be aligned and on the same plane. So now we're going to talk about the most common fractures, only the unstable ones First of all, we have a C1 burst fracture. The mechanism is axial loading, so any sort of compression from top to bottom. The most common cause is open water diving on shallow waters. It essentially causes a fracture of the anterior and posterior arches of C1 around here and here. And with the axial loading, it basically just spreads apart. It causes vertebral artery injury, which can limit blood flow to the spine, and is usually associated with fractures of C2. This is how it would look like, just the atlas itself just displaced horizontally. And contrary to popular belief, Jefferson C1 fractures are named after neurosurgeons, not at all related to the president. I know they always show you like the nickel, like right next to the fracture, but it has nothing to do with him. Or the nickel, yeah. It's just a neurosurgeon that discovered it. So that's essentially how it would look more images. You can see on this one. How can I go to that window? Huh? Okay. Here, how it gets displaced to the sides. And then the issue is that the occiput lies on C1, and so that's what makes it unstable. Then we have odontoid fractures. This is a fracture of vertebra C2, which is also called the axis. We have three types of odontoid fracture. Type 1 is stable, so we're not going to talk about that one. But the mechanism of action is flexion. Essentially, you get a fracture at the base of the dents around here. And this is associated to transverse ligament rupture, which is what holds the dents in with the atlas and the first vertebra, essentially, with the occiput. And then we have type 3, which is dens fracture with extension into the vertebral body. This is actually very unstable because C1 and the skull will move as a single unit. So you have like head-spine dissociation, essentially. So this one is quite severe. This one leads to quadriplegia most of the time. And that's basically. Here we can see the odontoid fractures. On picture A, you will see a type 1, on picture 2, a type B, and on picture 3, a type C. And that's the one that's the head-spine dissociation. You can see a type 3 here as well, and here as well. Then we have Atlanto-occipital dissociation. This is secondary to high energy impact. It usually causes paralysis of the upper extremities with lack of lower extremity paralysis or weakness. It's most common in children, and essentially what happens is that the occiput translates either forward or back from C1 and C2. It's usually more common in children. It causes internal decapitation, and it used to be immediately fatal, but now with now that we have EMS and all this pre-hospital system, people have some survivable outcome, but their quality of life is actually quite bad. And this is essentially how you see it. It's either translated forward or translated backward or completely just really far from each other. Essentially what you do is you have to pin the head back to C1 and C2, which I thought was cool. You also get Atlantoaxial dislocation. the mechanism for this one is flexion with blow to the back of the head. It causes rupture of the transverse ligament and causes C1 to dissociate from C2 in a rotatory motion. This is quite common in patients with Down syndrome, and they can actually have this with very minimal trauma. And here you can see the pictures how Atlas is not aligned completely with axis, essentially. We also have traumatic spondylolisthesis. This is also known as the hangman's fracture, and it is caused by extension. It's a fracture of the C2 pedicle, and spinal cord injury with this one is a little bit more rare. It used to be associated with the hanging. Let me see if you can see the picture. Because the noose itself would push extremely the head backwards, and that's what caused the fracture in itself. Hangings today are not associated with that because people don't use this type of arrangement with a rope. It's more here to backward, and usually what it causes is compression of the airway and no real fracture because it doesn't cause the severe extension that this noose would cause. Usually this one doesn't cause any spinal cord injury because C2 is quite wide and it just disperses horizontally. However, it's the disc itself that it squashes into the spinal cord that makes it unstable. And this is how it would look on the imaging. We also have bilateral interfacetal dislocation. The mechanism for this is flexion, and this is what our patient in the case had. You essentially had dislocation more than 50% of your superior vertebra over the inferior vertebra, which causing kinking or transection, complete transection of your spinal cord, hence the little sandwich. It's a very high injury to the disc, the vertebral arteries, and the spinal cord. It causes disruption of all the ligament structures, so this one just the only way to repair it is with surgery, and even then the outcome for these people is not the best. And this is how it would look. It's more essentially the pictures that I showed you before, but on this one here, you can see how you have like full transaction of the cord in this area or this area. There's also flexion tear duct fracture. The mechanism for this one is flexion, usually most common on C5 and C6. After the flexion, you get posterior displacement of the inferior vertebra, which usually causes anterior spinal cord syndrome. This one is actually quite hard. These people usually don't have any point tenderness, and the only way you're going to detect it is either by CAT scan, and even then sometimes it's missed. I think this is the last one. We also have burst fracture. The mechanism for this one is also axial load, so from top to bottom, and it's essentially complete squashing of the bone and disc, and it just displaces in all directions. For this one, the spinal cord might be injured if the fragments go into the spinal canal and affect the spinal cord in some way. And this is how you see it. Basically, like you sandwich it out. Oops, sorry, I lied. Another. Hyperextension dislocation is extreme hyperextension. It causes ligamentous injury, and it also causes central push syndrome. This one's actually hard to detect as well on CAT scan, and usually you need an MRI to make sure that there's no injury to the cord itself. And so see how this one is ever so slightly here. This is just an overview. I'm really bad with mnemonics, but essentially there's some mnemonic out there that says Jefferson beat off a handmade stump. I don't know what it means, to be honest, but I thought this picture was cool. Courtesy of Ben Wiseman. Atlanto-occipital dislocation, just to go over, it's high energy impact plus flexion, and you'll have complete dissociation. You have hangman's fracture, which is extreme hyperextension. You have Jefferson's, which would be axial load of C1 burst fracture. Your odontoid fracture, which is severe flexion, and you will also have dissociation of head and spine. You have your teardrop fracture, which is associated with extreme flexion, and your bilateral facet dislocation, which is due to flexion as well. Okay, I'm sorry that this lecture is very long. You can take a break if you want. Okay, so now to the evidence. To scan or not to scan these people? Should these people enter the donut of truth? Should they get a car wash, as some people call it, just full body scan car wash? So we have the Nexus criteria, which stands for National Emergency X-radiography Utilization Study. Nexus for short. Is a prospective study. It actually had a lot of people, 34,000. But it excluded patients over 65-year-old. They actually found that it was 99.6 sensitive. So it's pretty good for ruling out, but not very good for ruling in, essentially. The specificity was actually quite low. In the study itself, they identified of 118 injured patients. They missed 8 injuries, and of those 8 injuries, only 2 were clinically significant. So as per them, it was a pretty good study and, pretty good utilization of resources of who to scan or not to scan. If you take a look at the Nexus criteria, it's decided by absence of midline cervical tenderness, no focal neurodeficits, no more level of alertness or consciousness, no evidence of intoxication, and absence of painful distractive injury. However, this is all defined by provider's judgment. There's no clear set criteria as to what this means, so it's basically based on what you think or what you not think this is. There is also the CCR, which is the Canadian Cervical Spine Rule for Radiography. It's a prospective cohort study. It is a little bit smaller than the Nexus one. It was 8,900 people. It included 16 to 64 years only. However, their sensitivity was 100%, and the specificity was a little bit better than the Nexus one. However, the CCR is quite more complicated than the other one. So just to go over it, it is any high-risk factor, dangerous mechanism, see the right part, little star. Any motor vehicle collision at high speed, more than 100 kilometers an hour. For those that are American, that's 60 to 62 miles per hour, just in case. Rollover, ejection from vehicle, fall for more than 3 feet or 5 stairs. Any axial load, which is diving, collision with a motor recreational vehicle like a motorcycle or a bicycle collision. All of those are considered a dangerous mechanism and should get a scan. Anyone over 65 should get a scan. Any person with paresthesias should get a scan. After that, they decided they risk stratified on people with low risk, simple rear end motor vehicle collision, but this excludes people being pushed onto oncoming traffic, hit by a bus, hit by a large truck, rollover, or hit by a high-speed vehicle, which I assume is 60 to 62 miles per hour. Anyone with low risk is also be able to sit down in the ER, ambulatory at any time, delay onset of neck pain, and absence of midline tenderness. If the answer is yes, then you don't have to do anything. You go to the next step and you try to rotate the neck 45 degrees to the left and 45 degrees to the right. If the patient is able to, then no radiography is needed. The problem for this one is that there's a lot of criteria. It's hard to remember and it's labor intensive. From what I see, most people use a combination of two. Like they use the Nexus one to decide to scan or not to scan, and then they take it out, they do the rotation to both sides, 45 to 45, and that's usually what I've seen that most attendings do to clear people from their C-spine. They did a study in which they checked with Nexus versus the Canadian C-spine rules. They're compared both of them. The study with 8,000 people, and both of these studies found that the Canadian C-spine rule was accurate, superior, with a better sensitivity and specificity to detect spinal cord in cervical spine injuries. There was also a meta-analysis with a lot of people that also detected that Canadian had better diagnostic accuracy. However, all of these studies, Nexus and Canadian C-spine rules, were done prior to the use of CT scan. So it's either plain films versus no films whatsoever when studies were done. So I don't know how essentially they were able to detect clinically significant injuries with X-ray versus no X-ray. And then so they did a study as well that it was either CAT scan as the gold standard. Essentially, you're not missing any injuries, little to none whatsoever, compared to the clinical decision rules. And this one also showed that Canadian C-spine rule had a better sensitivity of detecting clinically significant injuries. The evidence for spinal stabilization using rigid C-collar is actually quite poor. The current practice is a result of historical precedents. All of these studies this has never been studied on trauma patients. This data is both from healthy or cadaveric specimens, so not really studied on trauma people. There's evidence that it's energy that causes harm and not the motion. So when the people coming to the ER, the damage is already done. There is no evidence that C-collar restricts movement. It can worsen injury on agitated patients or anyone intoxicated. Like you see all of our intoxicated people not wearing the C-collar how it is, and they're just walking around. Essentially, there's no evidence that it changes anything. And especially on penetrating trauma, you can have any missed neck injuries. It is also known that it decreases venous return, increases intracranial pressure. It makes it hard for you to manage the airway. And sometimes you're extending the spine to place the C-collar, and that can lead to worsening of injuries. Some studies have shown that actually just letting the person be in whatever position they're comfortable is what's best for the spine at the moment. So essentially, there's no evidence for rigid C-collars. The problem is that as ER physicians, we cannot do this in isolation. EMS needs to be on board, neurosurgery and trauma need to be on board. So at this time, I don't think we're close to be steered away from rigid spinal collars. We can also have skivora, which is spinal cord injury that we cannot detect on CT scan. And it's more the neurologic injury than bony injury. And these people who have persistent neurological deficits, most common on the cervical spine. It is more common in pediatrics than it is in adults. In adults, the East trauma guidelines actually suggest that you can discharge these people in aspen colors and they can get a follow-up MRI, but for pediatrics, you're supposed to admit them for follow-up MRI. But for adults, it is actually safe to do outpatient MRI with no surgery follow-up. This is how it would look like. You see how there is no evidence of bony injury, but when you take a look at the imaging, here you see that there's some edema around the spinal canal, and this can cause a myelopathy or like a particular neurologic deficit at that point. Then things that can cause spinal shock, neurogenic shock, are unstable cervical spine fractures. They're not the same thing. Spinal shock is when you have loss or depression of spinal reflexes below the injury. You will have flaccidity, loss of distal reflex, loss of voluntary movement. Neurogenic shock is completely different. So spinal shock is more lack of motion, lack of sensory because of your recent injury. Neurogenic shock is when you lose innervation of your sympathetic system. So you'll have relative bradycardia, severe hypotension due to extreme vasodilation. That is neurogenic shock. The treatment, though, it's more or less the same. You don't really get that much hypotension from spinal shock, but you still want to give them pressors because you want to give a MAP of higher than 80 or 90 to limit cord swelling. And for neurogenic shock, you want to have a MAP of over 80 and 90 to have good peripheral perfusion. And lastly, should we be giving steroids to the people or not? It's actually quite controversial. There is some evidence that it helps decreasing free radicals, lipid peroxidation, and injury itself to the cord, increasing blood flow. However, there are many studies that show that it has no benefit in long-term recovery, and it has increasing side effects like GI bleeding, hyperglycemia, poor wound healing, and poor post-surgical outcome. So ultimately, the decision is to be done by the surgeon that's going to be operating in these people, but there's also no evidence that steroids help at all. And lastly, that's it.